Thank you all so much for joining us today, and welcome to the third panel of Pluribus Unum's Truth, Action, and Reconciliation conversation series. We are so very grateful that you have chosen to spend the next hour with us. When we formulated the idea for these panels and discussions, we wanted to add voices to Americans calling to account our country's values and systems that reflect them. And to respond to that call, we knew that we must start with telling the true story of our country's role in creating inequitable systems. This week, we will discuss the history of inequities in our healthcare system. Since the COVID-19 pandemic, a new spotlight has been placed on health disparities, but our nation's history of racism and anti-Blackness in the practice of medicine goes back generations. And now we have our nation's top experts on the subject with us today. I am so honored to introduce our panel. Dr. Kamara Jones is a physician, epidemiologist, and civil rights activist. She is a senior fellow at Morehouse School of Medicine and just completed her tenure as the Evelyn Green Davis Fellow at Harvard's Radcliffe Institute for Advanced Study. Dr. Jeremy Green is a physician and serves as the director of the Institute of the History of Medicine at Johns Hopkins School of Medicine. Dr. Tony Esselin is a physician and serves as the medical director at City Block Health in New York. And moderating today's panel is Samantha Artiga, who is the Director of Disparities Policy Project at the Henry Kaiser Family Foundation. Now, Samantha, I'll pitch it to you. You guys have a great conversation.
Such a timely and important discussion, and I really appreciate the opportunity to be part of it. So over time, despite improvements in health, disparities have persisted and in some cases widened. Today, people of color continue to face increased barriers to accessing healthcare, often receive poorer quality of care, and ultimately have worse outcomes. Today, we're going to dive into a really frank and open discussion about the role that racism and discrimination play in driving these ongoing health disparities. We'll be exploring the history of racism and discrimination in American medicine, really discussing how that history continues to be manifested in the healthcare system that we see today, and examining how structural and systemic inequities in broader and social economic factors also influence health. So really, to get us started, I think it would be helpful for us to have a foundation and a framework for how we can identify and understand racism. Dr. Jones, I know you have written and spoken extensively on this topic, and you could probably fill the whole hour with just that. But can you get us started with some framework to set the tone and help guide the discussion for the rest of the day?
Yes, thank you, Samantha. And what I'll start with is a story, actually. A story that if I only have 4 or 5 minutes to communicate to people that racism exists, and how it works, this is the one I tell. And it, like many of my allegories, is based on something that happened in my own real life. So here we go. As a first-year medical student, I was, of course, very studious and diligent. So one Saturday morning, I wake up and I'm studying long and hard, right? I'm at it. And some friends come over, and rather than distracting me, we all start studying long and hard. It gets late, we get hungry, and I have no food in the apartment, which was typical for me. So my friends understood. They were like, never mind, Kamara, let's go into town and find something to eat. So we go into town, we find a restaurant, we walk in, we sit down, the menus are presented, and we order our food, and the food is served, and here we are eating. Not a very remarkable story about racism yet. But as I sat there with my friends eating, I looked across the room and I noticed a sign, and that sign was a startling revelation to me about racism. So now you're getting concerned and you're getting intrigued, and you're like, Dr. Jones, what did the sign say? What did the sign say? The sign said, open. So now I know I've lost many of you. So let me recap. Here we are sitting in a restaurant eating. I look across the room, I see a sign that says open. If I hadn't thought anything more about it, I would have assumed that other hungry people could walk in, sit down, order their food and eat. But because I knew something about the two-sided nature of those signs, I recognized that now the restaurant was indeed closed due to the hour, but firmly closed, and that other hungry people just a few feet away from me, but on the other side of the sign, could not come in, sit down, order their food and eat. And that is when I understood that racism structures open closed signs in our society, that racism structures, if you will, a dual reality. And for those who are sitting inside the restaurant at the table of opportunity eating, and they look up and they see a sign that says open, they don't even recognize that there's a two-sided sign going on, because it's difficult for any of us to recognize a system of inequity that privileges us. So, for example, it's difficult for men to recognize male privilege and sexism. It's difficult for white Americans to recognize white privilege and racism. And it's difficult for all Americans to recognize our American privilege in the global context. But those on the outside are very well aware that there's a two-sided sign going on, because it proclaims closed to them, but they can look through the window and see people inside eating. So back inside the restaurant, to those who ask, is there really a two-sided sign going on? Does racism really exist? I say, I know it's hard for you to know when you only see open. In fact, that's part of your privilege, not to have to know. But once you do know, you can choose to act. So it's not a scary thing to name racism. It's actually an empowering thing to name racism. It doesn't even compel you to act, but it does equip you to act, so that if you care about those on the other side of the sign, which is an if, but if you do, you could even talk to the restaurant owner, who is, after all, inside with you. And you could say, restaurant owner, there are hungry people outside. Why don't you open the door, let them come back in, or come in, and, you know, you'll make more money. And oh, the conversations we could have. Or maybe what you're doing is passing food through the window, or maybe you're going to try to tear down that sign and break through the door. But at least what you won't be doing is sitting back saying, wonder why those people don't just come on in and sit down and eat. Because you'll understand something about the two-sided nature of the sign. So this story has been to, and I call this story Dual Reality, a restaurant saga. This story talks, it's really not just about the sign. This, racism is structuring two-sided or multi-sided signs in our society. Is creating dual or multifaceted reality. But it's not just the sign, it's the door, it's the lock, and all of these things. And just in 10 seconds, what has happened right now in this nation is that those inside the restaurant, maybe some wind blew something, they got a glimpse of the other side of the sign. What I have to say is, people who are affirming that Black Lives Matter, who are saying structural racism, systemic racism for the first time, it's good to say those things, but unless you start acting, the seductiveness of racism denial in our nation could suck you back into what I described as the somnolence of racism denial. And if you say something today, 6 months from now, you may forget why you said it. But if you start acting, you will not forget why you act. So I just give that as a tool for understanding that racism exists. I haven't gone deeply into how it manifests. I'm sure that the other panelists will take us there.
Great. Thank you so much for that really powerful story and great framework for thinking about this. So really recognizing and reflecting on the history of racism and discrimination, specifically within American medicine, I think can really help provide us some important context for thinking about why and the reasons behind some of the ongoing health disparities we are continuing to see today. Dr. Green, can you help provide us some perspective on this history, and in particular, some of the pivotal events in history that have shaped the experiences we see today?
Sure, thanks. I want to also thank Dr. Jones for her analogy of her story, which has the added merit of being true in her own experience, as well as this allegory for trying to help as many people as possible gain insight into the problems of race and racism and health equity in American medicine today. I think that when you look back at the history of American medicine, it's really impossible to understand what medicine and public health are without understanding that race is so tightly tied up in this, and also vice versa, that the fields of American medicine and public health as professional, scientific, clinical fields have also played a large role in making race and racism what it has been over the course of our nation's history and our current lived experience. And as a historian and a physician, I find so much of my work is try to take us towards understanding that continuity as well as change in history. I think especially when we look at history and racism, we like to draw a bright line between the past and the present, oftentimes making a melodramatic kind of distinction so that we can find key villains. And then by telling their story, and this is oftentimes how the story of the Tuskegee Syphilis experiments come up, for example, say, well, we're not like that anymore. And I think part of the problem of trying to narrate a history of key events in the history of race and racism in American health and medicine is that it has it's a line that so thoroughly saturates all of the development of the field up to the present that that drawing the lines between these events, I think, becomes really crucial. We could look at a series of spaces, for example. So how does the lack of health equity, how does the differential burdens of disease and mortality on different bodies, right, specifically bodies that are racially marked, begin so evidently in 17th and 18th century histories of the Atlantic Triangle, of the movement of African bodies across the Atlantic into enslavement in the Caribbean and the American colonies and then the American states. Understanding the role of physicians, the role of medicine in trying to maintain the health of African American bodies in transition as investments, as forms of commodity, as forms of property. And understanding the role of physicians in a place like a slave market. Not just in the American South. I think we oftentimes localize or hyper-localize race and racism into the American South, whereas really it's an all-America saga. But understanding that there is a role of medicine in appraising the worth and soundness and economic value of different bodies of Black Americans. Looking past all of the ways in which medicine helped to prop up the horrible system of American slavery in the antebellum years, to then post-emancipation, after the failed promises of Reconstruction, in which the 40 acres and a mule was not provided, the different health outcomes of newly emancipated African Americans compared to their white counterparts was then pointed at by members of an exclusively white, for the most part, medical profession as evidence of a hierarchy of biologicized difference. And I say biologicized, it's a lot of syllables there, but it's reading the forms of social difference from the forms of difference that have been written on the bodies of people whose degrees of freedoms and basic nutritions and economic privations have been dictated by a system of slavery and the plantation. And then reading that immediately post-emancipation as some sort of tabula rasa, some sort of difference that was just evidence of a difference inherent to bodies themselves, inherent to kinds of people, and not to a local history that had just played out with such brutal and devastating force. And then I think if we continue to watch like what happens with the roles of medicine and health and difference in the years that are narrated by white America as the progressive era, but of course are also the years of the formation of harsh Jim Crow laws that enforce different forms of separate but unequal segregation. One moment of the progressive era that's celebrated in the medical profession is the 1910 Flexner Report, which is a report by Abraham Flexner on how to modernize medical education and bring up the scientific standards of medical education. Now, Johns Hopkins, the institution that I work at, was a key model for this form. But what happens in the wake of the Flexner Report is by creating a vision of what scientific medicine is and should be, that's really based on largely white institutions that privilege at this moment white male students becoming healthcare professionals, is we see the closure of a number of schools that existed at the time for African American trainings, produced African American MDs, just like we see the closure of a number of schools that produce women physicians, a number of women's medical schools. And so there's ways in which this progressive era is a great contraction. It's the era of Jim Crow, and it's an era of reduction of access, not just for Black Americans seeking formal healthcare through the healthcare system, but also reduction of access for Black Americans seeking to become professionals in the fields of medicine and public health as well. We can follow the story in the interwar years as we track the traces of the Great Migration, and think about the spaces in which Black Americans are and are not allowed to live at the ends of the various conduits of the Great Migration. And in my own city of Baltimore, which is an important terminus or nexus point in the Great Migration for many Black Americans in the early 20th century, there are only small parts of the city where Black Americans were allowed to live in Baltimore. And we can trace how that part of the city grows and what kinds of barriers are set in their way. But it's very explicitly established in the history of redlining that then emerges subsequently. And redlining is a way of understanding how it is that certain zones in American cities, or really anywhere in America, could be deemed differential risks for federally backed real estate lending, depending on the way that a particular geography was understood in racial terms. I don't mean to go on too long about this. I mean, clearly it's an entire course to teach the history of race, racism, and medicine, but I mean to trace it in the way that those areas of cities in America through the Great Migration that become coded as Black also become coded for divestment from federal and from state and oftentimes even municipal forms of support for materials that are supposed to be part of the Commonwealth, part of actually benefiting everybody, whether it's public schools, public swimming pools, public parks, public libraries. A relative divestment. This leads us in the post-war years into ways in which there's a similar form of redlining that happens in terms of access to healthcare. So the insurance industry is at first explicitly racially segregated. And then as it begins to, as mainstream insurance companies begin to willingly or by force insure African Americans, offer health insurance and life insurance to African Americans, they charge higher premiums for African Americans as well. And so by the mid-20th century, as the American way of thinking about healthcare explicitly ties health insurance to employment as a benefit, differential racial accessibility to different kinds of jobs which did or did not provide these benefits also immediately ties access to healthcare to race. And there's oftentimes an intermediate step, whether it's the redlining map or whether it's the way that we tie healthcare benefits to employment and then offer certain kinds of jobs only to certain kinds of people. But these structures are played out at a municipal, state, and national level, and they produce an enduring difference in who actually gets access to healthcare. And that's only on the basis of who actually gets access, whether it doesn't get at the beginning of the problem of what kind of care you get once you get access. But I'll leave it on from there.
Thanks, Dr. Green. I want to bring Dr. Estlin and Dr. Jones back into the discussion. Maybe Dr. Estlin, if you want to start, and then Dr. Jones follow. How well do you think this history of racism in healthcare is understood among the medical community more broadly, and particularly among white healthcare providers?
Yeah, I honestly don't think that it's recognized or understood at all. And I think that Dr. Jones has said specifically that we are an ahistorical community, right? One of the ways I like to illustrate this ahistorical phenomenon is with like a non-medical example. So a few years ago, there was the Wizard of Oz was redone, and the cast was an all-Black cast. And the comments of outrage were all based on, imagine if this was an all-white cast, how would we react? And that literally was the Wizard of Oz back in 1939, and that I watched religiously as a child in my childhood, right? And so the first thing is that we're just ahistorical. All the things that we just talked about, people just don't recognize or understand. And I think secondly, it's really important to point out that it's so easy to point to an individual as the problem, as opposed to the system as the problem. And so we can accept that slavery was a system that oppressed people, but it's over now. That has nothing to do with your current circumstance. Never mind the fact that that transformed into the Jim Crow era. Never mind that that transformed into the redlining that we were talking about, and differentiating access to education, to employment, and then ultimately to health. And so what happens when health and all of these other things, education and employment opportunities, become a personal responsibility, there's a disconnection. There's an absolute disconnection with the fact that all of these things, these sentinel events that happened in history, are actually connected. And the things that are these systems that are born out of racism are actually ignored and completely detached from what is actually happening. And so in health, you don't take your meds. You're not taking your meds. You're personally not responsible for taking your medications. Never mind the fact that you're actually making a distinction or a decision for your family about whether or not you have to eat today or feed your family or take your medications. It becomes a personal, it's not about the system. And those decisions are based on all the things that we just finished talking about, right? That's why they're in that actual situation. On top of that, you have providers like myself who were actually trained that health disparities, there's no why behind it, right? We're trained to memorize these things. We're trained to memorize that Black people have hypertension. We don't have a conversation about Black people have hypertension because of chronic stress and food deserts. That doesn't come into the conversation. And so I think to answer your question for like the broader community and the nation, we really have to revise elementary, high school, college curriculums to incorporate these subjects, to incorporate these sentinel events in our foundations of curriculum so that they're not just specialized courses that you take on the side. The same goes for medical education. That needs a revision so that we can incorporate these sentinel events in our educational processes. And it's not just, an interest group, a medical interest group on the side for social justice, right? This is all about, this is how you take care of human beings.
Wow. So amen, Dr. Esselin and Dr. Green. So I just wanted to tie a bow on some of the thoughts that we've already shared, and then I know Dr. Esselin is going to go deep on something else. So there are a few things we've shared. Health is not created within the health sector is number one, right? Like there are differences in quality of care. There are even differences in access to care. But the biggest differences causing differences in health outcomes are the differences in the conditions of our lives. And there are many people who do not know that there even are differences in the conditions of our lives across town or across the tracks by race because they were born inside the restaurant and have never ventured out, right? And so that's the first thing. The second thing about behaviors, we are so narrowly focused on the individual, as Dr. Esselin has said, that makes systems and structures invisible or irrelevant, but it also makes people blame people. Why are you eating so much fried chicken? Why are you this, that, and the other? We don't ask the why question. Why do some people eat some things and other people eat other things? When you ask that why question, you have to broaden your gaze beyond the individual to the social determinants of health, the context of our lives. But then you need to ask another why question, because it doesn't just so happen that some people find themselves in some context and other people find themselves in other contexts, that white people are overrepresented in wealth in this country while people of color are overrepresented in poverty. That doesn't just so happen. We think it just so happened because we're ahistorical. We think the present is disconnected from the past, and as if the current distribution of advantage and disadvantage were just a happenstance. But if we are honest, we need to ask why, and then we have to broaden our gaze not just to the social determinants of health like poverty and adverse neighborhood conditions, but to systems of power that can create the range of contexts that we see and then differentially distribute different populations into different contexts. And that's when we start talking about racism and sexism and heterosexism and colonialism, economic systems like capitalism and the like. So there's so many things. The other thing, so the narrow focus on the individual, the fact that we're ahistorical, I'll throw one more barrier in, the barrier to understanding, and these things actually make us also blind to racism. They lead into our racism denial, is our endorsement of the myth of meritocracy. The story that goes something like this: if you work hard, you will make it. I give you that most people who have made it have worked hard. Although not everybody who's made it has worked hard, and we have quite prominent examples of that right now. But even as we recognize that most people who have made it have worked hard, there are many, many other people working just as hard or harder who will never make it because of these uneven playing fields that are structured by racism and the like.
Great, thank you. So I definitely want to circle back and have a more thorough discussion about the social determinants of health and some of the history related to the barriers we see across sectors. I would like to spend a little more time diving in a little deeper specifically on the healthcare experience itself, and in particular, provider and patient interactions and relationships and the diversity of the healthcare workforce. Maybe Dr. Esselin, can you speak a little bit to those issues and how undercurrents of racism are at play across those different domains?
Sure. I mean, I think, like I said before, that I really truly believe the foundations of medical education and this curriculum needs revision. I really feel like that's a very important piece to this. And to illustrate that, it took for me to read Dorothy Roberts' Killing the Black Body for me to understand that the data around crack babies was flawed. That was such a frustrating thing for me to recognize, that while going through my pediatric rotation, the things that I was being taught was based on flawed science and actually racist ideals. The protocols in residency that we had to call social work on a mother who didn't have prenatal care, again, deeply, deeply steeped in racism and racist ideology. The fact that when we're taking exams, the question stems are deeply stereotyped, and that we're looking at an exam question. I can give you an example. 12-year-old African-American male with obesity, and the end of the story is to treat diabetes, as opposed to just 12-year-old with obesity, right? You make that relationship between obesity and an African-American male and diabetes, and that's what goes into your mind. The same with sickle cell. There will be a 4-year-old adopted from Kenya who presents in pain, in a pain crisis, and you're supposed to diagnose sickle cell. And so now you don't even think that, you see black pain, you think sickle cell. That goes all together. And the most folks that don't take their medications are non-compliant, and they're minorities, and they have poor diets, and they don't exercise, and they don't have education, right? And so when you're trained in this type of environment, you're not thinking, you're not having any critical thought. You're kind of a robot, and you're just kind of going through the algorithms, Let me illustrate this in terms of like relationships and how this manifests with a couple of cases, if I have a couple of minutes. So I have a 60-year-old Black male who comes into my clinic. He has hepatitis C, and he's not feeling well that day. He's losing weight, he's urinating a lot. We check a blood glucose, and his sugars are through the roof. And so we send him to the emergency room with a diagnosis of new onset diabetes. He gets to the emergency room, they take care of him. I start to review the documentation a couple of days later to see how he was doing. And in the emergency room, they diagnosed uncontrolled diabetes, risk factor non-compliance. Then you get to the admission, it gets better. I have another case. And then he gets to the admission floor. Now, of course, he's already been diagnosed in the ER with uncontrolled diabetes and non-compliance. And so that continues to his admission. So now what have we done? We've created a tragedy, right? Because here's this gentleman who had a new onset diabetic diagnosis that was written by his PCP, ignored, because here's a Black male with hepatitis C, probably has diabetes, not taking his medications. And instead of being discharged with instructions for a new onset diabetic, he's discharged as a non-compliant diabetic. That is a tragedy. That's just one case.
Can you then reflect on how this then impacts the community's relationship with healthcare providers, and when they want to seek care, and the extent to which they feel like they're being listened to and understood by healthcare providers? So how does the system and bias within the healthcare system then impact the relationship the community has back to healthcare?
Well, imagine you have that experience. You're not, who do you trust? Who do you trust? They're telling you that you've had diabetes and you just haven't been taking your meds. how can you trust that they're going to listen to you? You're coming in, you actually, maybe you even feel like the PCP didn't even have your back, right? Because your PCP is the one who sent you there with all good intention to have you get the care that you absolutely need, because you're getting pretty sick. And so now you've sent me to a system that is blaming me for my illness at this moment. How can you create a bond of trust? I have to give you one more case. So hold on to your hats, guys. This case gets me going. But I use it because it really illustrates what's wrong with our healthcare system, and it demonstrates the depths of how racism actually affects our healthcare disparities. So I have a 80-year-old male who has a very serious heart condition called atrial fibrillation, and he also has hypertension. And I'm actually the provider on the service. I'm the attending on the floor. So he comes to my team, and I'm religious about reading every single document that people have when they come to my service. And I start going through his discharge summaries, and he's been in the hospital 6 times in the last 3 to 4 months. So he's diagnosed with frequent flyer, non-compliant, this and that and this, back and forth. And I'm like, why haven't the alarms gone off for this gentleman, right? Like, why is he here 6 times? 6 different teams. He went through 6 different teams. They're all calling him non-compliant. It's always for the same thing. His heart just goes out of control, and he ends up back in the hospital. So I'm like, why? This can be managed. What's going on? So I go and talk to the man, and lovely gentleman with his broken glasses. He's 80 years old. And I start talking to him, and I'm like, what's going on? Why do you think you keep coming back here? He's like, I don't know. I keep coming to you guys, and you keep sending me back here. And I started to ask him, why? Look, tell me about yourself. Do you live home? Do you live alone? Do you have any family? Is anybody there to help you? No, he lives completely alone. He's 80 years old. And I'm looking at him, and he's like, I'm looking at his glasses. I'm like, when's the last time you had your glasses checked? And he's just like, oh, I haven't had them checked in a long time. They're clearly broken. They're clearly out of date. And so the whole time is that he couldn't read the pill bottles because his glasses needed an update. And because of the frequent discharges, he was mixing the doses up of his medications. This was a gentleman with insurance, so he was eligible for a home health aid that nobody thought about activating for him. So with a new glasses prescription and a home health aid, this gentleman could have stayed home. And this is a person with insurance. And so why is that? The reason why is because we look at Black, hypertensive, non-compliant, period. We're trained that way. We go this way. So we just fix the acute issue, and we don't think about how are we going to be able to sustain this person in the community. And this poor guy is looking for us to help. So how can he build trust in the community when he's going to the doctors and they're again saying, you're not taking your meds on time? And he's taking all of his meds. He's just taking them incorrectly because nobody's taking the time to find out that he just needs a little bit of help, and then he would be fine. He's totally an able person. And so I think that that's how these stereotypes, these preconceived notions, these assumptions about human beings play into our inability to take care of really sick people.
Dr. Jones, do you want to jump in?
I do, and it also is showing that our lives are not valued. I mean, it's just the devaluation of Black life, Black male life, Indigenous life, people of color life, which is part of racism. Racism is a system that does 2 things. It structures opportunities, so the disinvested communities, and it assigns value. And the white supremacist ideology, which was built on, you know, as Dr. Green was talking about, the history of biologizing the situation in which people found themselves when enslaved. White supremacist ideology is just the false notion of a hierarchy of human valuation by race with white people at the top. This is a very dangerous thing, which is being championed actually in our nation right now. This idea, it gives people who are living as white a sense of entitlement. It results in the dehumanization of human life, which we see in the stories by Dr. Esselin, which we saw in the casual crushing of the life of George Floyd, in the disinvestment in our schools, all of this, so that the dehumanization of us, the devaluation of our lives, and fear at the browning of America, which is motivating a lot of our politics right now, so that people don't even care.
So I think, this has been such a thoughtful, focused discussion on what we're seeing in terms of these issues within the healthcare system. I think we started to touch on the fact that we also see these same issues spread across sectors that all influence health. And I think what we've seen increasingly over the past few years in particular is this growing recognition and understanding that although healthcare plays a key role in determining our health, that it's really these broader social and economic factors that in fact have a bigger influence in our health. So things like our ability to access sufficient healthy food, our neighborhood and built environment, our educational and employment opportunities. I think, as you mentioned, Dr. Jones, there are similar issues related to what structures and systems have set up in terms of opportunities and barriers facing different communities, and also in terms of what is valued and what is not, and who is valued and who is not. Dr. Green, can you maybe provide just some brief highlights of some of the underlying historic policies that lead to certain communities and certain groups of individuals really facing a different set of circumstances across these factors, and in particular, I think discussing some of the ongoing residential segregation that we have across the nation. I wonder how well understood the degree to which residential segregation is still present, its connection to our nation's history. And then maybe Dr. Jones and Dr. Esselin, you can pick up on how that segregation influences health.
Sure, I'm happy to talk about this a bit. There's some excellent work that's been done by other historians of race and real estate. There's a great book by a Baltimore Sun reporter, Antero Piatella, called Not in My Neighborhood, which uses my own city of Baltimore as a way of understanding. And this is something the sociologist Lawrence Brown has called the black butterfly and the white L, that if you look at the city of Baltimore, you can see the segregation of neighborhoods by race, not entirely purely by race, not entirely purely by black and white, but in a very gestalt picture in these terms, as an L that courses through the center of the city and a black butterfly. And there's of where the predominant African-American neighborhoods are. Now, again, this is a generalized observation, but it's visible from space, right? It doesn't capture every detail of every neighborhood or every resident or any person who may or may not be a successful black professional living in the middle of the white L, or may not be a white inhabitant living somewhere in the black butterfly. But it's the way to understand the black butterfly and the white L in Baltimore, and there's similar patterns of hyper-segregation in almost every American city, and then also written through the suburban and exurban fabric of the rest of the country, is so often, as Dr. Esselin put it, given to us as just a data snapshot of this moment, right? And yet the way that this came to be was by how it was predominantly that certain spaces became very tiny, restricted spaces that were available for black families to set up shop in. And then when black middle-class thriving communities developed, whether it was in West Baltimore or in Tulsa, right, we see the incredible violence that could be unleashed on these spaces at any moment. And I think the nation is only just coming to terms now with the Tulsa massacre earlier in the 20th century. Which is a moment in which this neighborhood, which was called by the Black Wall Street, right, this thriving middle-class African-American space, was besieged, bombed by airplanes. There were federal equipment involved. It was one of the more explicit moments of racialized violence against a successful, flourishing black middle-class space. Which is just to say just how fragile these spaces have been in existing. And I think part of the trajectory from redlining policies in the 1930s, in which the federal government explicitly set up borrowing systems so that federally guaranteed mortgages could only be made according to a risk scale And that risk scale was understood explicitly based on the racialized characteristic of a neighborhood, right? And you can trace that into the story that Dr. Esselin was talking about how we all learned in the 80s and 90s to think about crack babies and to think about the crack epidemic as an objective reality of the danger of Black and brown spaces in American cities, rather than the result of a set of federal policies, including a tough on crime war on drugs, which then helped to produce further divestment from the public health priorities of the time. And so I'm afraid that I'm not laying out every single policy, but much as Dr. Esselin is suggesting, my real goal here is to emphasize continuity, right? Which is to say, we can't just simply distance ourselves and say, well, that's what they did in the 30s, or that's what they did in the progressive era, or that's what they did under Reagan, right? Because if we follow all the steps, it leads us into the building that we now inhabit.
I think that that continuity framework is really helpful. Dr. Jones, do you want to spend a little bit more time kind of emphasizing the relationship between where we live and what opportunities and barriers are presented to us, and how that is so directly related to what we then see in terms of our health and our opportunity to achieve optimal health?
I think that it's been well addressed by others. There's another book that I call people's attention to, The Color of Law by Richard Rothstein, where he talks about even after World War II, where the federal government was actively still segregating by race communities, which impacts the wealth development, it impacts all kinds of things. When you have a racially segregated community on the closed side of the sign at that restaurant that is actively disinvested, then you have poorly, if it's a poor neighborhood, poorly funded schools, poor educational opportunities, which often, results in another whole generation loss, which is showing up right now as people who are on the frontline jobs, who are, more exposed and less protected in terms of COVID-19. So when people think, oh my God, what's happening with COVID-19? Well, this is just another story about how racism and how it has structured our environments and actually also differentially valued us, how it is showing up as a health thing. It's just that the Black and brown bodies and indigenous bodies were piling up so fast that people were startled at first. But do you notice that we're not talking about those race-associated differences in COVID-19 anymore? They've already been normalized. They've already been normalized as part of, oh, that's just an expected racial disparity. Racism is a root cause of all of the race-associated differences that we see in health outcomes in this country, and in educational outcomes, and in housing outcomes, and all of that. Race is not biology. Maybe we assume that everybody knows that, but medicine has been very involved in biologizing race, this whole notion of biological determinism. But race is not biology. We have mapped the human genome. There's no basis in the human genome for racial subspeciation. So then when we try to figure out why do we see such marked differences in terms of health outcomes by race, well, people say, oh, well, maybe race is a proxy for social class. But it's a rough proxy for social class, but by no means, that is, Black folks, for example, are overrepresented in poverty, but not all Black people are poor. The plurality of poor people are white in this country. It's a rough relationship, and the only reason that there's any relationship at all is because of structural racism. Then people say, oh, well, maybe it's culture. Well, there's not one Black culture, or white culture, or Asian culture, or Hispanic culture. And within each so-called race, there are many, many different dietary habits and whatever. You could be called Black, been growing up in the rural South, the urban North, just come over from Haiti, come over from Ethiopia. Actually, you could be called Black coming over from Australia, right? Because what race is the social interpretation of how one looks. So it's not culture, it's meaningless for genes. What we have to understand that race is a precise marker of the social classification of people in our race-conscious society. And the same race that people noticed in the emergency department with Dr. Esselin's first patient, right, that made him non-compliant, the same race that made her second patient that she presented a frequent flyer, the same race that even just gets marked off by a medical admitting clerk, which becomes a health statistic, is the same race that a police officer notices, or a taxi driver, or a judge in a courtroom, or a teacher in a classroom. And it is that race that has profound impacts on the health and well-being of the nation. It is because of racism. That race is the substrate on which racism operates historically and day to day. All of these differences that we're seeing on the different sides of the sign are because of the structuring of the sign and the door and the lock. We have to all become actively anti-racist in our medical education, in our pre-K education. We need, as a nation, to be naming racism, then identifying how is racism operating here, and then organizing and strategizing to act. This is no time for us 6 months from now to be saying, oh, that was a cute little phase in our lives where we were all about naming racism. No, this has to become our national agenda.
I think the shift to focusing on racism as the determinant of a lot of what we're seeing versus race is such a really important distinction, and that more attention needs to be paid to it. E Pluribus Unum is really focused on our nation's focusing on truths to redesign systems and improve equity. It seems that recognizing and naming of racism is one of those key truths that we really need to understand in order to make progress forward. Dr. Aslan, Dr. Green, are there other really important key truths that you think we need to reckon with at this time, in addition to that, to really advance health equity?
I think that it is really important for everyone in this country and globally, actually, to recognize that we are all racist, whether we want to admit it or not, because that is the foundations of how this country, in particular, has been built, and how a lot of global structures have been built. I think we just have to admit that in order for us to move forward. That is a truth. I think that we need to recognize that health disparities work, and work in diversity is not a volunteer job. It needs to be paid. And I think that we need to all recognize that we can fix this, but we have to be intentional in order to do it.
Yeah, I agree with all of that, and would add to it that part of the problem of understanding race in American health is this this thing that Dr. Jones has said repeatedly as it's a hard word to say, right? Biologization, right? That we're not just biologicizing race, right? But we're constantly re-biologicizing it. So somehow differences are observed and then reinterpreted again in a new biological way. We saw this very clearly when the first racially indicated drug, Bidil, for the treatment of congestive heart failure was approved by the FDA. It was the first racially specific patent that was issued. And we don't have time to get into it right now, but the data behind this in no way suggested that this drug worked differently in Black or white bodies. It in no way actually suggested that there was really any biological way of differentiating Black or white bodies, right? And yet it had this effect of reaffirming a sense that Black bodies are different from white bodies. I mean, it was only one of a series of drugs to do this. We saw this with the thiazide diuretics beforehand. And again, not to take us through the whole history of this, but part of this is that this constant kind of gauzy or sort of thick, viscous fluid that we see the world through as healthcare providers that can't not see race and needs to learn to undo the various structures that are already always seeing race in every medical encounter. And that's why I think teaching an explicitly anti-racist curriculum to medical students, or teaching it through history in secondary schools in general, is so important, because it's not enough to simply say, I'm not racist, right? And it's not enough to simply say, well, I need to go through a bias training and understand that I have some sort of cognitive bias to certain people in certain ways. It's beginning to see the way that the structures are these fine lines that are invisible, that are all around us, and that condition not only any one person's advantages or disadvantages and the 1,000 cuts of social advantage or disadvantage that actually determine health outcomes, much more so than simply individual responsibility, but also within the healthcare system, that the things that disable one's ability to certainly just to treat the person in front of them like a person in the way that they would like to be treated like a person. And that saturates the stories you're telling, Dr. Esselin. So much of thinking about how to think about race and racism is to think about how to restore agency so that everyone can actually just equally be treated as a person. And that's part of the beauty I see in the Pluribus Unum project.
Great. And I know Dr. Jones wants to jump in, and then I do want to get to a few questions that have been submitted by our audience in advance. So Dr. Jones?
Okay, I just want to say that this system of structuring opportunity and assigning value based on so-called race, based on the social interpretation of how one looks, which is what we call race, this racism has three impacts. It unfairly disadvantages some individuals and communities. It unfairly advantages other individuals and communities. And it saps the strength of the whole society through the waste of human resources. I wish we had time to go on deep on that, but that third point, that racism, even if you are unfairly advantaged by the system, is sapping the strength of the whole society through the waste of human resources. We need to go there. And then I'm just need to say, Tony, I mean, Dr. Esselin, sorry. We're all friends here.
Yeah.
Anyway, that I am careful when I talk about racism to talk about it as a system. I am never trying to divide the room into who's racist and who's not, because it is the fear of being perceived as racist, or maybe they're looking at me and trying to decide if I'm racist or not, that keeps us from talking about racism as a nation. I recognize that there's a cement factory spewing cement dust. If we're around this factory long enough, we're going to have cement dust in our lungs. But our job is not to examine how much cement dust you have in your lungs versus you. It's affecting us differently, right? But we all have cement dust. It's not even to get a machine to draw the cement dust out, because the factory is still spewing it. Racism is a cement factory. It's a spewing cement dust. Our job is to, as individuals, recognize the factory, become individually starting on our anti-racist journey. Other people will ask, why do you have that gas mask on? You say, there's a factory spewing cement dust. And when enough of us have on our mask and figure out how to do it, we go in and we shut the system down. So it's the focus on the system as opposed to the individuals is the only way that we're going to stop this system.
And I think that's an incredibly important point. And I think that what we're trying to express is that we're all affected, right? Like this is not just, a white thing or a black thing. We're all affected. And if we don't recognize that, we're not going to be able to actually even identify the dust in the wind, right? And so I think that that's really important. And I do want to just add to what Dr. Green was saying, that it is super important in this sphere of us recognizing and becoming aware and having these conversations about racism to take the next step and act on it in some way, shape, or form. We can't just recognize it and talk about bias and talk about these things like microaggressions. It's like, now that you know, and that's what Dr. Jones's original point was. Now that you know that there's a two-sided sign, now what are you going to do? And I think we have to add that piece really intentionally to this conversation in order for us to get out of where we are now.
To that end, I think one of our audience questions was related to how we can overcome some of the trust issues that I think Dr. Esselin, you talked about being a response to all the mistreatment and unfair treatment that is frequently encountered within the healthcare space. Can you speak to some of the ways we can begin to overcome those challenges? I know you spoke to some of the education and training, but are there other issues you would highlight?
Yeah, I think that it's not a short-term thing. I think that we have to recognize that building trust takes time, and we haven't earned the trust of the community. And so we have to start building blocks so that we can earn the trust of our community. And in order to earn the trust of the community, we need to create all of the systems that we've talked about that we don't need to revise, that is going to enable for more Black scientists to be in existence, for more Black physicians to be in existence, in order for us to provide that shared experience to our patients that we so necessarily need in order to build that bridge of trust. So we haven't earned it yet.
And as we continue focusing on action, I do want to spend a little bit more time focusing on how can we really translate this recognition and increased understanding into positive action, because I think that's a great place for us to end as we're reaching the end of our time here. So are there some specific ways we can use the increased awareness and understanding and knowledge people may have gained from the discussion today to then translate into actual action. Dr. Jones, you want to start?
Yeah. I'll start just with, these are still principles that we can all apply. If you go back to the image of the restaurant, we need to actively look for evidence of two-sided signs. Is there something differential going on by race or by language or gender or immigration status or zip code? We need to burst through our little individual bubbles of experience to experience our common humanity on the other side of the sign, on the other side of town, to know that there's somebody just as kind, funny, generous, hardworking, smart as we are, who's living in very different circumstances. So we need to, our institutions as well as we as individuals need to create bubble bursting opportunities. We need to be interested in the stories of others and then believe the stories of others and then join in the stories of others, which we see right now in terms of the mobilizations and the protests. We need to develop a sensitivity to the absence of who is not sitting at that decision-making table. What is not on the agenda? What policies are not in place so that we can put important things in place? We need to recognize and reveal inaction in the face of need, lack of action in the face of need, because that is how structural racism most often shows itself these days. And for those on the outside of the restaurant, we need to know our power to recognize that action is power, and especially to recognize that collective action is power.
Well, as we reach the end of the hour, I just think that's a really powerful place for us to wrap up the conversation. I am so grateful for having this discussion with you today. I learned a lot. I hope our audience learned a lot and has taken a lot of this, is taking a lot of this home to think about how they can then translate that understanding into action. And now I want to hand it back over to Mitch to close us out.
Thank you, Samantha. That was just incredible, unbelievable, so edifying. I learned so much. You gave us so much to think about. Just a couple of things to summarize. One, now that you know, what are we going to do about it? Secondly, focusing on systems, not on people, to give individuals a way to come to a new realization. Third, and a really important point, Dr. Jones, that you made about this not only hurts individuals and is unjust, but it actually saps the whole of human resources. And I couldn't agree with you more. And then finally, in order to go forward, you have to be intentional. And as it relates to racism, you have to name it, you have to claim it, and we have to change it. A lot for us to think about, a lot for us to do. Thank you all so much for joining us today. Panel, thank you so much, Dr. Jones, Dr. Green, Dr. Esselin, and Samantha. Thank you for your wonderful work today. Join us next Thursday for the 4th conversation of EPU's Truth Series, where our topic is going to be economic equity. Thank you again for being with us today, and have a great and wonderful day and week.